back, guys. So today we will be continuing our topic. In this we are going to see myocardial infarction, one of the most important as well as most interesting topic you can say, right? So ischemic heart disease, just a short recap now. Four syndromes are present here. We know that already, that it's a ischemic heart disease is a group of syndromes where you will have angina, myocardial infarction, sudden cardiac death, and the chronic ischemic heart disease. And we had covered angina in detail in the last two lectures, right? There is three types of unstable, as well as prinzmetal angina. I am repeating this again and again because this should get fixed in your mind. When someone asks you about ischemic heart disease, then these four syndromes should come into your mind automatically. That is angina, myocardial infarction, sudden cardiac death, and chronic ischemic heart disease. Now, in this topic, we are going to cover myocardial infarction. That's the next two topics, that is sudden cardiac death as well as chronic ischemic heart disease. These two topics are not that much significant, so we will cover this in the next lecture. And just I will say about only the important points which you should know. This in Robbins also he has not discussed much about these two topics, because if you see this sudden cardiac death, the patient will experience chest pain suddenly and he may land up in death. Before giving any interventions and before taking any diagnosis, before taking any action, the patient will go into death. So it's like, what to say, not that much significant topic to discuss. But myocardial infarction, if a patient comes with a chest pain suffering from MI, and if you give a proper intervention, then the patient can get resuscitated. Let's go to our most interesting topic, which is the myocardial infarction. So just split the names here. This is first myo, and the next is cardial, and the third one is infarction. That means myo means muscle, cardiac means heart and the cardiac myocytes, and infarction, that means in short infarction of the cardiac myocytes. And now you should know that infarction means there is cell death, necrosis occurs of the cardiac myocytes, and it is totally irreversible injury. Keep it in mind. What do you mean by irreversible injury? General pathology, as I said you before again and again, in irreversible injury there will be cell membrane damage. The cell membrane damage occurs, suppose see this example. Suppose this is the cell, imagine this is the cell, and you have mitochondria and other organelles of the cell, along with that lysosome, etc. So this is the mitochondria, this is lysosome, this is the cell membrane. Now in irreversible injury, if you see anything that if a cell goes into irreversible injury, that means membrane damage had occurred. So here cell membrane damage will occur, lysosomal membrane damage will occur, as well as mitochondrial membrane damage will occur. Then what happens? The enzymes which are present in the lysosomes as well as the enzymes which are present in the cytoplasm, they will be released into the serum, that is into the blood. All the enzymes will be released outside, right? So that's why see in a patient who is suffering from myocardial infarction, there will be increase of troponin I as well as increase of creatine kinase, that is creatine kinase MB will be elevated in case of MI. Why? The reason is simple, it's a case of irreversible injury. So any organ you take, like the liver pathology or cardiac pathology, any system you take, if you see a patient has increased serum enzymes of any particular organ, that means irreversible injury had occurred to that particular organ. That's the conclusion. If there are no enzymes elevated in the serum, that indicates the patient has only reversible injury and not the irreversible injury. So in case of stable angina as well as unstable angina that we had discussed in the last two lectures, there will be no elevated enzymes in the serum. Whereas in case of MI, there will obviously be increase in the enzyme level in the blood. Got it? So we had understood the mechanism of irreversible injury and its characteristic morphological feature. And now here infarction, you know how the infarction occurred. That also I had discussed in the first lecture, that is the glycolysis pathway. I had connected this with the biochemistry topic, right? And you can write this if suppose in your exams this myocardial infarction come as an essay, then you can write all things like that, create a story actually using that, connecting this with the biochemistry. You should just have an ability to create this story, how you should prepare that, right? Yeah, okay. And so if we study, especially in Robbins, if we study, then how much we read, only 80% will be retained in our mind. And if we enter the examination hall, 50 to 60% will get retained in our brain. And when we see that shocking question paper, then the remaining 20% also will flush off from our mind. Only 30% we will be remembering at that particular time, and we'll write those 30% what we know, and the 70% we will write our own story. We will attach our own story. And it's a normal thing, it's a reasonable that everyone will forget something you write. It should be little bit logical and reasonable. You cannot write some irrelevant things in that story, right? It should be little bit logical, that the reader or the examiner who corrects the paper, he should at least have a knowledge that yeah, he has written some logical thing, we can give him marks. It will fetch you some more marks. So myocardial infarction, that means infarction, that is necrosis, in short, cell death occurs of the cardiac myocytes. That is irreversible injury. This sentence you know. Now what is the pathophysiology behind this? Why this myocardial infarction occurs, and what is the difference between this myocardial infarction and unstable angina? Especially you have to consider. Suppose the same diagram I will draw again. This is the blood vessel and this is the heart. We know that, okay? Now, as you said, atherosclerosis is the main cause of IHD. So here, this is the occluding atherosclerotic plaque. It has a fibrous cap and it is vulnerable plaque. It is not invulnerable. Invulnerable will not break easily. So this should be considered as a vulnerable plaque. Now what happens? Due to some stress or some sort of activity or even at rest, this atherosclerotic plaque ruptures. There is a complication of atherosclerosis. It ruptures. As it ruptures, the subendothelial collagen gets exposed and it activates the platelets. Now all the platelets will come in, it will aggregate. Adhesion of the platelets, aggregation of the platelets, this all will occur, leading to the formation of thrombosis. Now this thrombosis will occlude the vessel totally. Mark my point here, this you should know, the thrombosis had actually occluded the vessel totally. In case of unstable angina, the thrombosis had occluded the vessel submaximally. That means a narrow lumen was present so that the blood can flow through it easily. But here in this condition, the atherosclerotic plaque, after getting ruptured, the thrombosis had occluded the vessel totally. That means blood cannot flow through this. Even small amount of blood cannot be passed through this occluded vessel. So the heart will suffer a lot. It will undergo ischemia a lot. It will undergo ischemia easily, and this condition, due to the complete occlusion of the blood vessel, that is especially the coronary artery, the heart goes into a state of myocardial infarction. Got it? This is the difference between unstable as well as myocardial infarction, which you should never forget. Now the same thing here. There is atherosclerotic plaque. Wait a minute. Atherosclerotic plaque, it should be vulnerable so that it will get rupture easily. If it ruptures, thrombosis will occur, and this thrombosis should completely occlude the vessel to cause myocardial infarction. So you can think like that. First, a patient came to your clinic with a complaints of chest pain, stable angina. Okay, he didn't came to your clinic at all. He was suffering from stable angina initially, chest pain, and then he progressed to unstable angina, and following unstable angina also he didn't receive any intervention at proper time. Then he finally landed up in, this is a sequence actually by which the patient can develop myocardial infarction. Okay, now we had learned about the pathophysiology in detail. Now coming to the types of MI, myocardial infarction, there are actually 3 types of MI. One is the anterior wall MI, lateral wall MI, and the third one is inferior wall MI. There are 3 types. Let me tell you 1 minute. Yeah, so this is the anatomy part I will be telling now. Now this is the heart, as you can see here, and I will change my color of the pen. Wait a minute. That is let me take this violet color. Okay, now this is the arteries. This is actually left coronary artery. I am marking, see here, this is the left coronary artery. Now after giving a branch, that is the circumflex branch which goes laterally, the artery becomes the left anterior descending artery. That is the LAD, left anterior descending artery, which is the most important artery of the heart. After giving the circumflex branch, the artery is called as left anterior descending artery. it supplies the anterior part of heart. That's in which groove it is running, that all anatomy part I will not be discussing here. So just imagine, just keep it in mind that this left anterior descending artery will supply the anterior part of the heart. Whereas, see, this is the right coronary artery. Here it is, I am marking that. So this is the right coronary artery. It runs on the right side of the heart and supplies a marginal branch. You can see this. The marginal branch runs on the inferior surface of the heart. Again I am telling a drawing here. So this is the right coronary artery, and as it goes down it gives a branch, that is the marginal branch, which runs on the inferior surface of the heart. Okay, inferior surface is made up of right ventricle. The right atrium will take over the right border of the heart totally, and the inferior portion of the heart will be made by the right ventricle, and the left ventricle will form this left heart border, and the apex will be formed by the left ventricle. Okay, this is the general anatomy to know the types of MI. Now what happens if this left anterior descending artery gets blocked by the thrombosis? Then it leads to anterior wall MI, as the anterior wall of heart will not get blood supply, leading to infarction. And if this circumflex branch gets occluded, that leads to lateral wall MI, because the circumflex branch is supplying the lateral wall of the heart. Now the blood is not going there due to occlusion by the thrombosis, that leads to lateral wall MI. And now talking about this right coronary artery, if the right coronary artery gets blocked by the thrombosis, then this marginal artery which is running inferior, that also will go, and that leads to inferior wall MI. Three arteries which gets blocked in three types of MI are: in anterior wall MI, which artery is blocked? That is the left anterior descending artery. And in case of lateral wall MI, that is circumflex branch. CB means that is circumflex branch of left coronary artery. And the inferior wall MI occurs due to the blockage in the right coronary artery. These three things you should know. We had seen this. Coming to the clinical features. What are the clinical features? Severe squeezing, chest strangling, crushing type of chest pain. Let me put it in this way. Suppose a patient suffering from chest pain, okay, came to your clinic with the chief complaints of that is chest pain, and he is keeping his fist in his sternum like this. Am I visible? I don't think I am visible. Yeah, like this. He is keeping his fist in his chest like this. So what is this sign called as? This is actually called as Levin's sign. You will read in medicine, okay? So if the patient is coming and he will have this features, like it will be, the patient will tell it's like something squeezing my chest, that is some strangling or crushing type of chest pain is present. Okay, and the one more thing is it will last for more than 20 minutes. You have to make a diagnosis, ordering some investigations, and then intervention should be done at the proper time. Okay, now, and this pain will radiate to the left arm, as you know, that angle of jaw as well as the neck. And dyspnea, why dyspnea occurs? I had said you before, as this heart goes into ischemic state, that is infarction state, it is not getting blood supply, so the heart is suffering a lot. In MI especially, the heart suffers a lot, and that signal will be go to the brain, and he will tell the brain that, see, I am not getting any oxygen, any blood, please help me. Like that he will the brain, and the brain, what it does, it cannot say something is occluding the coronary artery, it will just order the lung, see, my heart is not getting enough blood, try to give him more amount of oxygen. So what does lung do? Lung has to obey the order of the brain, so it will undergo hyperventilation, which will lead the patient to go in a state of dyspnea, there is difficulty in breathing. Okay, and one more thing is the symptoms are not relieved by nitroglycerin, and this in case of stable as well as unstable angina, also in case of Prinzmetal angina, usually the chest pain gets relieved by nitroglycerin, or if not relieved totally, at least for some time he may get improved. But here in MI, symptoms will never be relieved by the nitroglycerin. Got it? Because nitroglycerin causes vasodilation by converting into nitric oxide, but here thrombosis had occluded the vessel totally. Now if you vasodilate or vasoconstrict, nothing gonna happen. Now coming to the ECG finding, this is an important topic. Basically it is a little bit medicine oriented, so if your people final years are seeing this, then it should be helpful for you guys. In ECG finding, initially there will be subendocardial necrosis. Initially, the patient may have subendocardial necrosis. The patient initially develops MI, he will face subendocardial necrosis. And what happens at this stage? ST segment depression occurs. You know that if the subendocardial ischemia or necrosis occurs, so ST segment should get depressed. And followed later, what happens is the myocardial ischemia will progress to transmural MI. When it progresses to transmural MI, the ST segment will get elevated. This is the point here. In case of stable angina, it will be depressed. In case of unstable angina, the ST segment will be depressed. In case of principal angina, due to vasospasm, all the three layers will get compromised. All the three layers will get compromised of blood supply, so it will be ST segment elevation in principal angina. In MI particularly, initial cases you will have ST segment depression, and at later stages you will find ST segment elevation. But practically this is not possible. If the patient develops initially chest pain, it will not be like suddenly, slowly he will develop. At that time subendocardial necrosis will be minimum. At that stage he will not come to the doctor, he will not come to you, right? After he develops some severe chest pain or some sort of say dyspnea, he will come to your clinic. At that time you will mostly find transmural MI, so ST segment elevation only will be present. So suppose if anybody asks you what will be the ST segment finding in case of MI, you should say one and only ST segment elevation. Don't say ST segment depression. But if he purposely asks you at the initial stage of MI what will be the finding of ST segment, then you can say that ST segment depression can be present due to subendocardial necrosis. But practically this is not possible, because the patient will not come to you when the initial slight some sort of chest pain. When the patient develops transmural MI, that time only the patient will come to you. At that time if you take ECG, you will find only ST segment elevation. Okay, so this point you have to remember. So this is the, wait, I will close my video now to explain you. See here now. So PR segment, suppose this is the P wave, you can see here P wave, this is QRS complex, this is actually QRS complex. Now this ST segment, it is straight, that is isoelectric segment. This is a normal ST segment. Okay, this is normal ECG. But here in the next one you can see this is P wave and these three are QRS complex. You can see here the ST segment has elevated, and this segment you can see this is the ST segment which is getting elevated, that is convex upwards. Convex upwards, that is the Pardee sign or tombstone pattern, which is this one. You can see here the ST segment elevation which is looking like tombstone pattern. This is a characteristic finding of myocardial infarction. In MCQ also it will be useful. Tombstone pattern or Pardee sign. You can see it's a Pardee sign. P-A-R-D-E-E. This is Pardee sign. So these are seen in case of myocardial infarction where ST segment elevation occurs convex upwards. It is convex upwards. There is some condition in which concave upwards will occur. That is actually acute pericarditis. That you need not to know here. It's a case of medicine. You just remember in case of myocardial infarction, ST segment elevation occurs and the finding will be tombstone pattern, that is the convex upwards. ST segment elevation convex upwards. Okay, and in initial cases there will be ST segment depression. You can see here diagram, ST segment depression. The ST segment is depression. It will be present only in case of initial MI, and after developing transmural MI he will develop ST segment elevation. Now let's go to the lab test. This is one more important topic to be discussed. Now lab test. The two main enzymes or two main key markers you can say which you should detect in case of MI is one is the troponin I and the other one is CKMB, creatine kinase. Troponin I, it is sensitive as well as specific for MI. Okay, and it rises 4 hours after the myocardial infarction. It will reach the peak at 24 hours and it returns normal at 7 days. After developing MI, troponin I starts to rise 4 hours after this, and then it reaches peak at 1 day and it comes back to normal at 1 week. So 1 day, 1 week, like that you can remember. And in case of CKMB, you have that is creatine kinase MB. You have 3 types of creatine kinase isoenzymes. You would have read in biochemistry. There is creatine kinase MB, creatine kinase MM, and creatine kinase BB. Creatine kinase MB is situated mostly in the heart and as well as little bit in the brain, and creatine kinase MM is particularly located in the skeletal muscles, and creatine kinase BB is located mainly in the brain. Okay, here for heart our topic of interest is CKMB. There is a creatine kinase MB. It starts to rise obviously 4 to 6 hours after MI. You can, for easy remembrance, remember this is also 4 hours, this is also 4 hours. Approximate range is 4 hours, and it peaks at 24 hours. Again the same like troponin I, it will reach the peak at 24 hours and it will become normal at 72 hours. That means within 3 days. Within 3 3 days CKMB comes back to normal after MI, whereas troponin I takes approximately 7 days to get returned to normal. Significance it has, yeah. CKMB can be useful for recurrent MI. Suppose a patient suffering from chest pain came to your clinic with the complaints of obviously chest pain is present, Levin sign is positive, that is he is keeping his fist in his sternum, and you suspect of MI myocardial infarction. You order the ECG showed the tombstone pattern, RD sign, convex upwards, ST segment elevation, and you have decided, yeah, he may have myocardial infarction. So you check his, you order some lab test and you check it troponin I and CKMB. Troponin I after 4 hours it starts elevated, and CKMB also it gets to start elevating after 4 hours. Then you give some sort of treatment modality, the patient becomes normal. Then after some, we imagine that's after 5 days or 6 days, he is again developing chest pain and coming to you. Okay, now what you will do? Whether that's a case of MI again, recurrent MI had occurred, or it may be due to some other conditions. It can be like gastroesophageal reflux, that also can cause a little bit epigastric pain, right? So what is the real cause? Whether it's due to MI only, again MI had occurred, or it is due to previous MI, it is continuing up to now, or it may be due to some other disease. How to find out which is that? Further, if you check the troponin I level, what it will show? Because it takes approximately 7 days to become normal, it will be elevated only. Even if you give proper treatment, even if the patient is recovered from the myocardial infarction, the troponin I levels will be increased for approximately 7 days. After 7 days only it will come back to normal. So it cannot tell you that recurrent MI had occurred. So in this case, CKMB comes into useful, even though it's not as sensitive as well as that much specific when compared with the troponin I. This can tell you whether recurrent MI had occurred because it comes to normal within 3 days, that is 72 hours. So within 3 days it comes back to normal. Again, if the patient develops MI after 5 to 6 days, and this CKMB will be again elevated, that indicates that again the patient had suffered from the one more MI attack had occurred. So by this way, CKMB can be useful for detecting recurrent MI, whereas troponin I is the sensitive and specific marker for detecting MI. So this is the difference between the troponin I as well as CKMB, you should know. Okay, now the treatment part. Discuss the treatment part and we'll conclude this session. So what is the treatment? It is aspirin as well as heparin. Aspirin is, as you know, it's an antiplatelet, and heparin is an anticoagulant. And this treatment part, you will learn this in detail in pharmacology. And just touching up here, the MI should get completed overall. And the treatment, supplemental oxygen you will give obviously, and nitrates, the function is it will decrease the preload. There is something preload, something called afterload. You will learn this also in pharmacology. The nitrates will decrease the preload, that means the amount of blood which is going to the heart, that will be little bit decreased, so that the burden upon the heart gets reduced. As the burden upon the heart get reduced, diastolic period will get little bit extended, and during the diastole, the blood flow through the coronary arteries will increase, leading to the blood supply to the heart. Because the heart gets its blood supply only during diastole, so the diastole period will be little bit increased if the burden on the heart gets reduced. And one more is the beta blockers. So if you give beta blockers, what it does is it will reduce the heart rate, then the demand of the heart is also reduced. By this way, you can calm the heart. You are calming the heart, you are consoling the heart to keep quiet. And one more thing, the final treatment, which is actually gold, you can consider it as a gold standard, is like angioplasty. Angioplasty, what you will do here, you may throw a guidance where you will pass through the coronary artery, and under guidance only you will localize where that occluded thrombus is present, and you will remove that thrombus, and if required a stent will be placed there, so that it should not get re-occluded again, it should not go into a state of vasoconstriction. You will keep a stent there, and through that stent the blood can flow easily to the heart. Now if you do this angioplasty, reperfusion to the heart occurs. There are some complications which will occur due to reperfusion, which you would have read in general pathology, that the main complication is reperfusion injury. Now what is this reperfusion injury? There are mainly two complications of reperfusion. One is the reperfusion injury and the other one is contraction band necrosis. In reperfusion injury, suppose this is the blood vessel and this is the heart. This was the occluded thrombus. Now you are putting a guidance wire and you are actually removing this occlusion. After removing the occlusion, it will be like something like this, and you had placed a stent here. Something it was like that. Now the blood is easily flowing through this. As the blood is easily flowing through this, along with this blood, inflammatory cells as well as the oxygen will go to the heart, obviously. Now heart has both the damaged myocytes which had been damaged due to myocardial infarction. It can be either anterior wall or lateral wall or the inferior wall. Along with this, you will have normal cells, surrounding normal bystander cells also will be present. So damaged and normal cells both are present in the heart. Now as these inflammatory cells as well as oxygen is reaching the heart due to blood flow, these inflammatory cells will also kill the normal myocytes. It will start destroying the normal myocytes. So if you are destroying the normal myocytes, it will worsen the condition. This is called reperfusion injury. Now what is contraction band necrosis? Suppose this is the blood vessel and this is the heart. Now you had removed the thrombus and you had placed a stent, something like this, and by which the blood is flowing through this stent easily. Okay. Now as the blood flows through this, there are some, I said you before, the damaged cells are present as well as normal cells are present. Normal cells are, this is actually damaged cell. Now damaged cell, irreversible injury had occurred. That means cell membrane damage, all the membrane had been damaged. Now what happens is, this blood, if it goes, then the calcium influx will occur easily in the damaged cell. As the cell membrane is damaged, more amount of calcium will come inside this cell. What is the function of calcium? You would have read in physiology, that is contraction. Calcium causes contraction, C for C. That means it will activate the myofibrils, and myofibrils, that is acting myosin, that will come into action and it will lead to contraction. And due to this severe contraction of the damaged myocytes, complication occurs that is actually called as contraction band necrosis, which you will visualize in pathology slide. That is after taking the biopsy. See here? You can see here, this is the cardiac myocytes, and the cross striations which should be present, they are all lost. The cross striations are haphazard, they are not present, and some places, see, you can see here one nuclei, it is violet in color, somewhere here it is, and the nuclei are also not arranged properly, and some of the nucleus are lost. Nucleus are not present due to pycnosis, karyolysis will occur. There is also general pathology. This nuclei will get lost, and you can see here, this is the wavy pinkish, there is eosinophilic, okay, inclusion like substance. This is actually called as contraction band necrosis. This occurs due to the calcium influx, which causes more amount of contraction of the damaged cardiac myocytes, leading to the contraction band necrosis formation. Okay, the things which you have to remember in this condition is, in contraction band necrosis, what you will see in the histological slide, that is H and E, after taking biopsy, is there will be nuclei will be absent. Nucleus is totally absent, and you will see this wavy pattern of contraction band necrosis, and the cross striations which should be arranged normally, that is haphazardly arranged, and it is cross striations are actually lost here. Okay, these three things: nuclei lost, cross striations lost, and wavy pink eosinophilic pattern, which is called band necrosis. So these three findings you should know. And practically this is not possible to take a biopsy of the heart, right? If in a living person you cannot take this biopsy. This has been taken mostly when the patient had died due to MI, and after doing the autopsy, they would have removed the heart, they would have taken the sample from the heart, as in the case of biopsy, and then they would have sent that to histopathological examination. But practically, if you speak, you cannot take biopsy from a living patient. That's a logical thing. Okay. Now we had seen, just short recap, complication of reperfusion. One is the free radical injury, that is due to reperfusion injury. This is free radical injury, is a separate topic which should be dealt in general pathology. Okay, due to the return of oxygen, what happens? All the inflammatory cells come here and it destroys the normal myocytes, leading to worsening of the condition. And if you are talking about the contraction band necrosis, that leads to reperfusion of the damaged cells, and more calcium influx will occur. Calcium influx will occur a lot, and that leads to myofibrils contraction, hypercontraction. You can say myofibrils hypercontraction, that leads to contraction band necrosis, loss of cross striations, and the nuclei will be lost. Okay. So these are the complications we had seen. With this, we are concluding our session of myocardial infarction, but still we have to learn about the morphological features of MI. What are the microscopic changes, what are the macroscopic changes, and what are the complications at different stages of MI we have to learn. Here we had seen only the complications of treatment of angioplasty. If you are reperfusing the organ, what are the complications we had seen? But the complications as a whole of myocardial infarction, its microscopic changes and macroscopic changes, that will be dealt in the next lecture, along with the chronic ischemic heart disease and sudden cardiac death, which are other two types of ischemic heart disease. Okay, so with this, let us conclude our session. If any comments, feedbacks you want to give, you can share it in the comments section. I will respond to that. With this, we can conclude. Thank you so much for being with me.